Good morning, everybody. Thank you very much to EHTEL for the invitation, and to Stefan Schuck for the invitation. It's great to join you today. My name is Kerry Thompson, and I'm the Deputy Head of the eHealth Wellbeing and Aging Unit in DG Connect. So we're the only health unit in DG Connect, and we liaise a lot with our colleagues in DG Santé, DG RTD and others on this work on health data that's so important. And before I start with the slides, I mean, I haven't really put any COVID-related information in the slides. They're slides from the pre-COVID era, which seems like ancient history now. But I think what we've seen in the Commission, what we've heard from the stakeholders, for example, stakeholders on the pharmaceutical side who are developing vaccines, is that, we need to accelerate this work on developing health data and health data space. And they're certainly relying on electronic health records to large databases of electronic health records, not all of which are in the EU. And they see a great need to strengthen this as quickly as possible. So, and of course, on the digital transformation side, we're also seeing in member states the rapid uptake of various kinds of digital tools and services. A classic example being the telemedicine, which has really skyrocketed now. I think people are having a change of mindset, and we're seeing that it's enabling health systems to keep up their resilience and continuity of care, for example, for chronic patients in this era of COVID. So the message we're getting is it's got to speed up, and I think this is the message that we're getting everywhere and that we're internalizing as well. So if only we had this data space sort of fully set up, how it might have changed the picture in terms of the speed with which we could come forward with solutions. But already it's clearly helping the response. Okay, I'm just going to turn off my camera. So if maybe you could just, I'm going to talk to you about effectively the data strategy that we adopted in February 2019. And also, how this ties into the health data space as well. So maybe you can go to the first slide. So, I mean, from Connect, where we've got an interest, of course, from across society for all sectors, all usages of data. We're really leading on the data strategy per se. And Commissioner Thierry Breton particularly, of course, wants to see this data made available so that the EU and all stakeholders can really reap the potential of the digital revolution and make full use of the tools, new digital tools, artificial intelligence, high performance computing, to change our practice, to boost our industries, to make ourselves healthier, to green our economy, and so forth. If you go to the next slide. Strategically, I think one of the messages we wanted to give out to stakeholders is that sometimes you hear in talks that the EU is not the top operator, that we need to compare ourselves with other parts of the world. I think what our analysis shows is that between now and 2018 and 2025, there's going to be a great shift still in the way that data, the volume of data that's used and the way that it's used. And so principle among the shifts will be to see a change in the current model whereby most data is processed in a cloud and fairly limited processing takes place in handheld or local devices. And we envisage not only a rapid increase in the data volume, but also in that particular dynamic. So to see less data, comparatively speaking, a lower proportion in the cloud, and much more of the analysis moved towards your device. So what that says to us is that if we're strategic now and put in place the right investments now and galvanize our ecosystems now, we've got the opportunity to be very well placed in the future and lead in the data area. If you go to the next slide. So, what we're after, of course, is a digital single market for data. I mean, we talk in this kind of community particularly about health data, but there's so many interactions between different kinds of data. There's a point at which we don't see it in individual sectors, because we need to make one level read across to just a data space per se, not linked to particular sectors. And of course, critical is this issue of a common data space across borders, a single market for data, so as to really deliver on the digital single market with appropriate frameworks in place, clear rules for the access and use of data, and be fully respected and available to those who can add value to it. So if you could go to the next slide. But we have, to get there, we have a lot of problems we have to overcome. First up, making the data available. We need more data. We need to really deliver on this message about the reuse of data and get more public sector data available and not languishing inside databases unused. Where to make it to also not just the public sector but also encourage the private sector to share as much as they can if they've got data that they don't consider to be particularly relevant for competitiveness regions, or maybe they can even be persuaded that there are incentives and value in sharing even some of their more competitive data. We also want to boost European data processing and storage solutions. We have quite a small cloud industry compared to other parts of the world here in the UK, in the EU. We want to try and encourage that to grow. Something we're particularly well versed in the health sector is this issue of data governance approaches. And it's a particular issue with health data, the issue of seeing the data become interoperable, seeing common approaches to things like the secondary use of data. It is essential if we're going to get this moving, the data and seeing the data in the volume that we need to see it in for artificial intelligence to really prove its worth. We want to keep, so far at the moment, I think we would say, particularly campaigners for patients and citizens would consider that we haven't sufficiently got ourselves in a position where the user is fully empowered. So we need to change a bit the paradigm here and create systems whereby individuals, who are the entities which are producing the data, in the case of health, that citizens feel fully in control. And of course, we need to develop the skills and shortages across the board, citizens, professionals, companies. It's essential. So you can go to the next slide, please. Yeah, so our strategy has essentially 4 pillars. One is about creating or developing further these cross-sectoral governance frameworks. Of course, we have some in place already. We have developing cybersecurity framework. We have the GDPR, but we need to go much further with that. And if you look at a number of our, particularly in the health systems with the health data domain, we're going to have to think about particular issues around data access for sensitive data like genomics and for electronic health records. It is critical in this area. We're also talking about what we're calling enablers on this slide, where we envisage, depending on the, of course, we're waiting still for approval for the Digital Europe programme and its overall budget. But what we're interested in seeing there is an investment, a joint investment potentially between the EU and the member states of very large sort of infrastructures that can create, that can be used in a pan data kind of way for all data spaces, that can be very large structures that can see data flow across the EU, from which all sectors can access, and it can be a fundamental basis for all sector data spaces. As I mentioned earlier, of course, there's the whole side about investing in competences, capacity building for companies and individuals, and in our health world, this is also hospitals and healthcare providers. And then we want to see this, if those first 3 pillars are very much horizontal pillars, if you can allow me a horizontal pillar. The last pillar is really a pillar where we're talking about really going into the sectors. And here, if you go to the next slide, we have a nice slide that shows the range of sectors that we're talking about in particular. Health is nicely at the beginning of this slide, which is great, but of course we're aiming for these horizontal actions to happen across all of these: agriculture, industry, manufacturing, finance, mobility, Green Deal, energy, public administration. Because of course, if you take the example of health, particularly if you go into working around health and other policies, you'll see that the impact, there's a lot of just for the health domain alone, there's potentially a lot of data in these other sectors that we would bring to bear in developing health policy or health pictures, or understanding better what's driving health in these in different countries. And so across all these sectors, we need to have, in each one, we need to have a certain degree of sector-specific standards and interoperability, specific tools around data sharing, particular kinds of perhaps a horizontal resource for developing data governance, which can be drawn down by sector and tailored by sector where it's necessary. And of course, each and one will make its own use in some way, in a framework way, of different kinds of IT capacity, such as cloud storage, processing, and services. If you could just go to the next slide, then I'll just tell you briefly about, you don't have to linger on the next slide, it's about the data strategy that was published in February is now open to consultation, and we would urge everybody who has not yet given any feedback to do so, because we said we completely rely on your feedback. You know, we don't want to create anything in a bubble. So if you have any issues or remarks, I do urge you to go there. It's open for another 11 days. You could just go now to the next slide. And so there are a number of other aspects on top of this overarching digital strategy which relate, which I think are very relevant, particularly to developing all data spaces, and particularly the health data spaces around. In this case, we have a concept called testing and experimentation facilities, which we're exploring with member states in different sectors. So we've explored with member states in a workshop we had in January, and also with some stakeholders, this concept for trying to find ways really to make the data available to the innovation community. So what do we need to do? And what do the innovation community need? And we hear stories from SMEs involved with creating healthcare tools with artificial intelligence, about the need for different kinds of data at different phases of the development process. So we're consulting on this issue, and we hope to be. There's a lot of member states interest from member states, and we're trying to understand really what model would exactly work with regard to health and care. So clearly, in other sectors, for example, there's very much a case of having, you need the data for testing your product, but you also need other things. I mean, in the area of robotics, you would need space. In the area of smart communities, they want to have particularly space to test, for example, driverless cars along with AI. So what we've been trying to understand from stakeholders is what do they need, and in addition to the data, which is clearly critical. And on the data side, then I think it's going to be clearly a question of making our data available, and in a way that satisfies both GDPR and privacy concerns, but is also useful for data for innovators. So to this end, for example, we're exploring research into innovation, anonymization techniques, and so forth. If you want to go to the next slide. Critical as well is cybersecurity. We've been developing the framework for cybersecurity through the NIS Directive and the Cybersecurity Act. We're identifying hospitals as critical infrastructures for key capacity building, and this is something as well that we want to use the Digital Europe programme to support, because this is clearly going to go hand in hand to creating, to seeing the full potential of the digital transformation at hospital level, and it goes hand in hand with the data usage itself. You go to the next slide. Alongside this, as Connect, as the health unit sitting within Connect, I think one of our roles is really to be regularly screening and looking across the organisation, interacting with our colleagues, working closely with the new generations of technology on blockchain, supercomputing, algorithms, and of course quantum technology is coming up as well, 5G, Internet of Things, to be talking to our colleagues, to be understanding how it is these can be, and understanding from stakeholders too, how could these be exploited for use in the healthcare system, and how can we make this happen? And this is another part, of course, taking forward this healthcare space. It's got to be able to absorb promising new technologies that can be useful and effective in health and care. If you want to go to the next phase, the next question. High performance computing. This is This is particularly, I think, showing its value right now in this era of COVID, as we have a project, for example, ongoing, Escalate for Cove, which has been set up as a partnership between the Commission and the member states dealing with high performance computing, and several companies, several pharma companies, that have made available through agreements their molecular databases of molecules for rapid scanning using artificial intelligence to review in the light of COVID and to see which molecules may be relevant in terms of repurposing old drugs. And so we hope that there will be results coming out of this project actually in the next couple of weeks. But this is a message we've got very strongly, that this is something that we can. This is particularly relevant, of course, to the speed with which we need to find both vaccines and potentially new treatments for COVID. So I think it's. I think you're probably all too familiar with the value of HPC, but it's become very, very powerfully. A very powerful tool to communicate to, for example, parliamentarians about the need to really accelerate the data strategy right now. Okay, so now that was, in a way, so far, it's about the frameworks. It's about the different capacities that we need across all data spaces, particularly health. And the way that we're seeing health itself is to think of it in a series of the data spaces, to think of it as a series of use cases. If you go to the next slide. Kyriakides was given, Commissioner Kyriakides was given the mandate in her mission letter from Ursula von der Leyen, the President, to develop a health data space. And then this was also reiterated and announced as well through the data strategy. So if you go to the next slide. We have some work that's ongoing in this respect, as you're probably familiar with, from and was also highlighted in our communication in 2018. The eHealth DSI is an infrastructure already up and running in a limited capacity, in the sense that it's connecting most but not all countries, and it's starting to see the transfer of clinical data from one country to another, particularly in relation to the patient summary and e-prescription data. So this is a beginning, but through the work that we've proposed in the recommendation of the electronic health record exchange format, we're now going to do some work to broaden the technical specifications to new use cases, to new health information domains in terms of images, laboratory results, hospital discharge letters, and we aim to see these develop now in a project that we're going to kick off in the autumn, hopefully, and see them as they're developed and taken up, agreed by the groups who need to agree them, and then taken up and adapted health infrastructure. And this is particularly an infrastructure that's looking at primary usage of data, so it's data that's going, but we need to explore how to, on this particular use case, how to develop the secondary use for exploring electronic health records, how to develop a framework whereby we can find ways to interrogate electronic health records and give access to it to all those who can add value to it, including the innovation community. Another critical use case, if you go to the next slide, I think you're familiar as well, is with the Genomics Declaration, where we are linking. We have a project ongoing, a process ongoing with member states. Again, many, indeed most member states, although not all, because it's a voluntary initiative, and we've started in 2019. We're also hopefully about to put money behind a project that will give extra resources and boost to this process, because so far it has really been the member states on their own and with different levels of resource. And we aim to, under the debt, we would like to explore, the development of an infrastructure then that will actually enable this data in a federated way, because the data will remain in the member states, to become accessible to certainly researchers and in time to the wider community as well. And this will need a careful work on the governance, because of course like electronic health records, is extremely sensitive data. So if you go to the next slide. So those are two use cases that are ongoing. But we see we're seeing the e-health data space, the European health data space in this way. Through the data strategy, we're investing in a lot of major infrastructure, horizontal frameworks, tools and services that can be adapted for use in the health sector. And then looking at the health domain itself, we've got some use cases starting, and we hope to explore more in time that will see a piloting of infrastructures. Once successful, then an expansion and a connection to this overarching framework, whether it's the use of clouds, the use of high-performance computing, algorithm stores, and so forth. And with the ongoing work, as we'll have in all domains, on the quality aspects, such as in terms of the interoperability. So at the end of the day, we've got, within the e-health data space, we've got these key usages. We want to use the data for better healthcare, better policy making, better research and innovation. And as with the other data spaces, we're going to have to look at we're going to have to agree over the coming years, the governance. This is really a challenge and a priority for the current Commission. The governance of these aspects, boost the quality, create the infrastructure, get it up and running, get it working, launch use cases, piloting. Once they're mature, start to see their rollout and expansion alongside active work to build capacity in health system, support and investment, both from the EU and hopefully from member states, in the form of capacity building to healthcare providers and to citizens and so forth. So if you go to the next slide.
Carrie, if I may,
that may be it.
I see just in the chat a question for Mark. What means verification? Is it the famous findable, accessible, and so on?
Yes, exactly. It's this issue. It's this sort of very well. It's of course applicable to all kinds of health data. It's about findability, accessibility, interoperability, and reusability.
Okay. And
indeed.
Then
Yes.
Go to the next slide. Sorry, I was maybe.
Actually, before you go to the next slide, let me just go to the slide on the right, the pillar on the right-hand side. I've mentioned about My Health at EU, which is in fact a rebranding of the eHealth DSI, this infrastructure which is up and running, which will need expansion. I've mentioned the 1 million genomes. Another use case is in this. It links to these European reference networks, which are dotted around the EU and which are centres of excellence for rare diseases, and they have their own internal system for sharing data across borders called the CPMS. So this is another budding resource which we're looking at more closely to see whether and how that can be expanded. There's another project that the European Medicines Agency, another use case, are interested in, which is about getting a pilot up and running to see how they can link databases of electronic health records, ostensibly for their particular use cases, which is around using the data to support the regulatory process, but it's actually can also be seen as a kind of pathfinder project for generally for how you link electronic health records. We've then got work to link different repositories such as registries, cancer registries, transplantation registries. We have an images database project that we have set in motion and will be starting work soon, which is about developing a large resource of anonymized images for cancer research. And we have the research infrastructures as well, which are particularly around for the research usage. So I think the next few years we'll see a large investment. We'll see great work to try and really develop the governance, because this is a critical clue to the healthcare system. If people, both researchers and governments and individuals, want to all feel comfortable that they're using the data in the right way. So this will mean setting up agreements, probably linked to individual infrastructures, and then a continual work to be developing the quality of the data that's transferred, particularly in terms of this verification, as you mentioned, and the electronic health record exchange format. Yes, the EMA is the European Medicines Agency. It's terrible how one gets stuck on acronyms.
Okay, but I think the question is, because it says in the slide regulators, and Darwin is the name of the project, right?
Absolutely, absolutely, yes. So Darwin is a project that the European Medicines Agency is proposing, and for the purposes, because their role is to provide a European approval for medicines. So they need the data from electronic health records to be able to audit really what the pharmaceutical companies are providing them in terms of the relevance of the value and efficacy of their drugs.
Okay, thanks a lot. So,
do I have another slide? I cannot remember.
The final one.
That's it. That's the last one. Yes. Okay.
So I also checked it.
So that was a rapid run through, and I'm very happy to answer questions if there's still time, or we can leave them to the next speaker, the next period.
Oh, thanks a lot, Carrie. That was very insightful. We have indeed, okay, we had some clarifications in between, and then we have one question here in the chat, which I'm going to read out to you. It's from Eric Paul from ANU Governance. What would be the bold action Carrie would recommend to make health data space a reality soon?
I think, I mean, you know, you come to a topic like the health data space. I mean, when we're talking to our colleagues in across Connect, who are dealing with other data spaces, we are a very particular data space, I think, in health data space, because we are it's by far the data space with the highest quantity of sensitive data. So I think we cannot. So I think three things have to happen. Many things have to happen in parallel. We need the work to create the infrastructure. And that is a very big idea, I think, in itself. It says fundamental, huge investments across the EU to create a resource that all the data spaces can use, and that will be of immense value, particularly to the health data sphere, because genomics data, for example, it's very high volume. It needs a lot of bandwidth to be moved around. We need these big resources. We've got to have the quality taking place. This is a very complex problem in health because of the way in which individual member states are particularly responsible for their healthcare. So healthcare systems have grown up, health data systems in member states have grown up in isolation from each other, and now we're having to connect them, which is not the case in all the sectors. They were much more, I think, linked much earlier on. So this is a very particular challenge for health. And the control of the citizens and the governance for citizens to feel that the data is controlled is a third thing that's particularly relevant for health rather than to other sectors. But the next year or two will be, I think, instrumental. We're watching an initiative going on now, which I think that particularly the Germans want to continue with in their presidency in the second half of the year, to really nail down a common approach to GDPR for secondary usage, and this will be critical. And so I think what we'll see is a mushrooming over the next couple of years of these elements, and then a sort of connection of it all, I think, by the end of the mandate is what we hope. So that there'll be, I think, where we will be in 3 or 4 years' time will be quite different to now. But I see it as an evolution. Yeah.
Okay, thanks a lot. I think that was a strong message. Of course, we are now coming to the next block where we will see a presentation coming out of the OpenDI context and by IDSA. And to understand what we are talking on there, you will quickly pass on the floor to Luc Nicolin.
Good morning, everybody. Thanks, Stefan, for the introduction. So very quickly, OpenDI is a CSA, which has as main objective to work with 4 different domains, and that's a bit also something pretty new, to try to discover what we have in common between health, energy, manufacturing, and food, for example. And so that's quite an exploring journey that OpenDI wants to do. So just very shortly, the way the work is organized is a bit specific, because we have an ambassador in each domain, which is trying to pass on the right messages and the right needs coming up from all the different domains, and to try just to identify what we have in common and what is specific to our domain. So actually, the work is organized with working groups operating in each domain, while OpenDI will provide a support at different levels. So you see them on the left side. So it's basically trying to have an overview of what is taking place in the different domain, observing also the different pilots which will be implemented. Also trying to build an ecosystem where we share better the resources together. We identify the standards we are using, and we see which one can be used more widely. So the more standards can be used across domains, the better, naturally. And also to create a common identity, at least within each domain, and then also as an overall community. So that's very, in a nutshell, the key messages of OpenDI. So it will be working on those issues for the next 2 years, and from there on, I pass you on back the microphone.
My name is Michael Johansen. I come from Medcom in Denmark, and I have these 3 slides prepared for you. If we have to look ahead in the next 10 years and give a little story about how we think the next 10 years are going to develop, I would start looking a little backwards in the history to see what have we done in Denmark in the last 25 years. What we have made 25 years ago is a backbone messaging system, which is run on old EDIFACT standards from profiles from SEND standards. And they are in the native Danish language, so that's a big problem for us right now. So it's an old point-to-point transportation of messages, and it also includes some mapping between some formats. We also support XML in Denmark, but it's also national XML standards. We have a plan we made last year for a substitution of this old network. So we will implement e-delivery, the European way of messaging data. And we have already decided in Denmark that the next generation of public mail is based upon this e-delivery network. It has the benefits of being an open network, so every company who can join the onboarding process of e-delivery can exchange messages in Denmark. It enables the possibility to message cross-border, but it also have the benefit of having the same technology when you are in the health domain and also in other domains in the society. After running this for 10 years, we found out we needed a more service-oriented backbone, so we have established that. So we have a national service platform upon we have built IHE document sharing. And during the last 5 years, we have made all new standards in Denmark in EHTEL 7 as documents we share. This national infrastructure had a lot of services, for instance, for logging and also for blocking certain organizations or clinicians for having access to the data. It also includes a notification service amongst other components. Next slide, please. And I think this slide is a sort of, if you choose next slide 4 times, I think you can to spare the time. It's more easy to. Thank you.
Sorry.
Yeah, one word. Yes. Then we have this. I have two stories to tell here. The one is what happened due to this COVID-19 pandemic, and where were we prepared for it, and where were we not so prepared. And we had a problem with this messaging data and sharing data. We saw that the pandemic raised some new needs of data and access to data. But we have a prepared strategy which we expect to implement in the next 10 years, where we combine the paradigm of sharing data in a national service platform. We will combine that paradigm with the messaging paradigm. So you can get a combined access to all the health data existing concerning a patient. So we have a modernization project. We have planned it, but we couldn't use it in this situation of the pandemic. We have another modernization project about the messaging we have in Denmark, which is rather Danish, and that's a huge problem. So we had decided a strategy which is called abandon ship. So we move away from all the messaging standards we have in Denmark, and we implement them from start again using HTML7 fire messaging. So it's a very huge project for us, and we plan it and expect it to take between 3 and 8 years. The symbols in the bottom of the slide is showing the backbone network we have in Denmark, where we get access to a lot of national repositories for medicine, laboratory results, discharge letters, etc. That's the gray boxes to the left. And to the right, there are some yellow boxes, which are data that comes from the patient herself. It could be monitoring, home monitoring. It could be questionnaires, which a patient administer and take the measurements themselves. So they're personal data. But in the right corner, you see the GP, who also have a connection to the patient. The patient uses an app which gives direct access to her personal doctor. They use that app for access to bookings and also to get in contact for consultations with the GP. That is running directly and not with. We have a lot of communication between the municipalities and the GPs, and what we expect is to combine them so that these data also is accessible in the national infrastructure, and that national infrastructure we can put into the to the access point of national data. Yes, I'll say very few words about it. It's about video conferencing, where we were very prepared. We had all the infrastructure ready, and this COVID-19 just meant that we had to make a technical scale up, a very large scale up, and we were able to do that very fast. And that had been a very great benefit in Denmark.
Okay, very good. Thank you indeed. Okay, so that was Denmark. Sorry, I come back. You can see me. And the next in line will be Finland. Vesa, you have not slides, but I think you will say a few words.
Okay, for the case of Finland, we of course we run the national Kanta services, which is a kind of centralized integrated system that contains healthcare and social welfare data as well. And in regard to the secondary use, we have already an authority called FinData in place that started to collect as a kind of one shop way aggregate data and release aggregate data by applications to the customers already in the 1st of January. They went on to personal level data the 1st of April. So there's one contact site where everybody can ask for data, and there are law-based or legislation-based delivery time limits for that. When it comes to this COVID-19 case in Finland, this is considered as the most severe event since the World War II. This has been stated in public too. We have seen a plethora of new electronic services brought to the market, dashboards, bot type of systems, medical devices with CE markings, remote visit systems, and so forth. And one of the biggest issues has been, as we closed the working places and so, the distributed working model that actually was turned on within 1 week only. And it has been stated that in Finland, the most recent 4 to 8 weeks, the progress has been faster than, say, 5 to 10 years before that. So that's the pace of working. We have a lot of databases, of course, in electronic form in Finland in place for various use cases, and we are fortunate that we can utilize these data to monitor and analyze the situation in Finland and, of course, also in abroad. EHTEL is the central coordinator for that kind of activity. And we feed these monitoring and analysis results to the government situation room, so to say, and also we release the analysis and data for the public use also. So this moment of COVID has been a real big booster to innovations and development efforts here. A couple of words regarding the COVID-19 infection case in Finland. In Finland, we call that epidemic, and of course it's pandemic worldwide. Here you have as a y-axis number of issues, and here you have a picture of persons in hospital care by day, persons in intensive care units per day, and the number of beds per day. And you see the flags here that the 10th lab confirmed case appeared the 3rd of March, the 100th just week after that, and 1,000 cases we had within a couple of weeks after that. So exponential increase in the number of cases. In Finland, we utilize these 3 indicators just to mirror the actual epidemic that is going on, because this picks up the most severe consequences of the epidemic in epidemiological sense. But still, the numbers are rather small if I compare other fellow countries. And you see that already in the 2nd or 1st week of April, the indicators turned from increasing to a decreasing trend. And if I put a linear ruler issue here, we will arrive something like a week or so before midsummer, what is a big feast here in Finland. So we see that in Finland, due to rather exceptional conditions and legal issues, and even putting one of the municipalities in a full quarantine, we have turned the epidemic curve to a declining trend. So this was what I wanted to show you as a kind of not greetings, but the issue and status of the COVID epidemic in Finland.
So I will now pass on the floor to Luc Nicolas to say something on the situation in Belgium.
So basically in Belgium, the approach which has been followed was a fully decentralized one. So basically the use of the cloud was not per se a central issue for sharing health data. As what we adopted as an approach was that the data would stay where they are, but we would define exchange protocols and a broker in between, which would be data agnostic, only dealing with metadata, which would make those data exchangeable in the whole network. Next slide, please. So the basic idea, which is extremely generic and scalable, was to design 3 layers. Basically, as public authorities, a significant amount of investment was needed in order to build the trusted data we all need to organize a number of services. And so that relates to clearly to identity of people, to identity of care providers, but also to the drugs, to the authorization process, to the description of all the healthcare providers in the system, and so on and so forth. We have just developed centrally a number of basic services, and then with those sources and those authentic sources, services could be developed. That was very much the idea. So that's extremely scalable. But next slide, please. The idea was, first of all, of course, to help to develop a number of services for the exchange of clinical data, but clearly many other actors came with specific needs. And that was, for example, all the organization dealing with registries, who had all their own system, their own way to do it, their own data information model, and so on. So we saw that very early in the process, we had to find a way to avoid that data had to be re-encoded multiple times, and thus to make possible data reuse, basically, and avoid multiple entries. So we took it from the end user side also, to begin with, say this is too much of a burden. Now that we have the generic architecture, we need to find a way to avoid that, and so that the same data can be used for multiple purposes. And that's the idea of health data, which is basically to build bridges between the clinical domain and the health knowledge, epidemiological, and other possible domains. Next slide, please.
Luc, if you allow a quick question, who is health data? Is it an organization or is it a concept?
That's an organization which has been placed within the Belgian Public Health Institute.
Ah, okay.
But it's a sub-organization which is specifically dedicated to this. And so we made an analysis of what we could find, at least we minimally, in each health data, which was encoded in clinical systems. And we've seen all the data which were needed by all the registries, and we said, how can we make sure that what is existing can at least be reused? So that was a very important job to map this up. And so that was a tool which the tool which has been developed is basically starting from that. It's not the tool of that we'll be using in 10 years from now, but at least that has allowed to start to use the clinical data, to transform them semantically when it was needed with a number of mapping, and then only to complement what was needed for the specific purpose. So the automated on semi-automated data capture for secondary use in order to seed most of the Belgian registries was one of the first priority action for data reuse. Next slide, please. The other, next slide, yes, okay. The other element which was very important, it's not only to was not only to make data reuse possible, but also to better orchestrate the services in such a way that the same data could be used for multiple services, even in the care domain. And the example of drugs is extremely significant because at different points of times, everybody came with his own objective. Pharmacists wanted to have the pharmacist share record, e-prescription has its own finality, and the shared medication schema was again another initiative which came up from the primary care sector. So there was a huge need for orchestration. And then it raised just the need to organize the health data space around medicines in a completely different way. Next slide, please. And we ended up with this, with a responsibility for the public health authorities and the competence center, which was basically the reorchestration of all the data sources necessary and the creation now of repositories to guarantee a full use of the medication data for all the finalities and for the public authorities to be able to assume their responsibilities. So both for prescription, for agreements, for deliveries, for administration, with a possibility for the patient to be empowered also in this system. And that's also very much of the idea for me of a health data space, basically, evolving from a fully decentralized approach towards when we believe there is a high added value, sometimes for a more centralized approach for a number of data, of metadata. Next and final slide, please. So with priority data sets, that's one of the issues we wanted to tackle today. It's the first need is to better orchestrate existing health data spaces, which have, although there is a generic architecture to share data, still organized very much in silo. And also links with new sensitive, new kind of data, like the genomics, which have already been mentioned earlier. That's probably going to be the first priority. And then we have also now, and we see it very much, I will not come back to the COVID-19 situation, but there is an increasing need to connect to external trusted data sources, which were originally not seen as priority for the health domain. And so they are linked to all the health determinants. So the social factors, the environment, food basically can definitely provide important information also for the patient health, and personal behaviors, and the whole world of Internet of Things. The last idea is basically now, which is emerging, is that, and we've seen that recently also in a regionalized content, shouldn't we, as public authority, organize a personal cloud space for each citizen, which also would solve partially, at least, the solution, the question of the consent, where all personal data could be shared with a governance which would be agreed upon. We have done that through messaging systems. So for example, in Belgium now, a secured, guaranteed email exchange protocol is existing for each citizen to deal with public administrations. But beyond that, that's now the full exploration of the space for individual patients, including for health data, which will be explored. And that will be my final sentence.
Okay, thank you, Luc. Okay, now I have with the cloud, I think that's a very nice catchword to come back to the questions we have passed out. I think since I'm here in chat with Hannes Schieter from Dresden, maybe Hannes, we give you the word very briefly, but I'm afraid that we cannot go to any details. Maybe you could limit it to the medical informatics initiative if you would like to make a point. The floor is yours.
So this is our region where we briefly introduce. We have two university hospitals and a big size hospital located in Chemnitz. The main mission for its hospitals is of course to organize the whole care in the regions. From these e-health infrastructure and platform and data centralization attempts, there are a lot of different activities ongoing in Germany. We have different private initiatives building local platforms, also data-oriented platforms, but also integrare enabling platforms. We have a big initiative in 2012 where the region spent 12 million euros for building a telehealth platform as a software as a service approach, so that you can plug in integrated care applications. This is now moved to another solution, to the Carus Connect. I don't want to spend here too much, so these are more or less private organized initiatives. In parallel, there are spent a lot of money in building specific solutions. This picture is more or less dedicated to the situation from 2008 until now in our region, though the government spent about 40 million euros in different telemedicine projects. Very or a nice or what means nice, an important fact here is that this was going in parallel to a national initiative, to build up a telematic infrastructure. So we have in Germany the case that since 2004 there is a claim that we will get national infrastructure for building up telemedicine service, so the telematic infrastructure, so-called telematic infrastructure, that is now taking place. But this contradicts in the past a little bit the attempts to build up telemedicine solutions in a national system. So we have a lot of several projects that build up platforms or build up also data repositories for research. And we have now more or less the phase I illustrated here in below, that we are now in the phase of integration and harmonization. So we are now in a stage that we have the telematic infrastructure running. The most of the outpatient, inpatient sector are connected or will be connected recently. So we have this health VPN, and we can organize a lot of value-added service, like the electronic patient record will come in the next year, treatment reports and so on, though this is organized on this infrastructure. In parallel, we have a nice initiative. I will post the link. I come to the end. We have a nice initiative. This is a Medizin Informatik initiative. It is a consortium, or there are several consortiums of university hospitals in Germany that are dedicated to the sharing and analyze of data for secondary use. So how we can use primary data to investigate new situations, for instance. And this is an initiative which is very important and well founded in Germany, which takes more and more place and will organize the complete secondary use of data. But right now they are working on the inpatient sector to connect the data of different university hospitals. In the second stage, they are envisaged to integrate also the outpatient sectors. So it has been started 2 years ago. I guess, more or less, yeah. And it's now taking place and organize all the things about the secondary use. Yeah, maybe Stefan has also some additional comments on this. In Dresden, we are connected to the Miracon consortium, which is where Martin Sedelmeier is the contact person in Dresden for this. This very briefly, wrap up. I think there are some catchwords for you, and if you want to have further details, please contact me or Stefan, and we can give you further insights to one of those topics. Thanks for this.
Okay, thank you, Hannes. So let me come back to the questions that have been raised. Okay, they have been partly answered by the contributions that we have seen. You see here the first question: are cloud solutions already large in use in healthcare? What are the barriers, and so on? So this gives me the perfect, let's say, lead over to what is already in the chat, namely that we have prepared a follow-up survey, which does both invite you to provide us some feedback on the webinar, and also, more importantly, input for the consultation. So if you click on the link which you see now in the chat box, you will end up exactly what you see now on the screen. So our follow-up survey, and you find in the first part then indeed a little bit of feedback for the webinar, but very important is that we are preparing a contribution to the EC consultation on the European strategy of data that has been mentioned by Carrie in her presentation. And so we need your input very soon. So please reply not later than Friday, 22nd of May, end of business. And since weekend is always a strong help, last minute acceptance will be Monday morning at 9 CET. So and you have the link in the chat box, and it will also be sent by you in an email follow-up after this meeting. And this leads me to the final announcements. We have also in the Imagining 2029 webinar series, we have two other work streams besides this ELO one. One is exploring digital therapeutics, artificial intelligence, and virtual coaches, which is part of the Innovation Initiative Work Program for 2020. And the webinar has now been fixed for the 3rd of June. You will find you will receive more details, titled "How Can Hospitals at Home or Care at Home Benefit from Digital Therapeutics?" And we have another work stream still, sorry. Oh, now I'm very nervous mouse, sorry. Which is run by the Digital Integrated Task Force, Digital Integrated Care Task Force, which works this year or has started to work under the headline of Building Health Data Ecosystems for Integrated Care. And there's also a webinar upcoming in June, the value of combining personal and professional health data for integrated care. And you will find all these webinars in the webpage at here, the link Imagining 2029 HTML. And of course, I cannot touch it here. I thought I could copy it in the stream, but it's you will find it also from our homepage. And last but not least, also in this thematic stream, we will have additional webinars. We have two in the pipeline. The first one will be end of June on making real-world data fit for EHDS, for the European Health Data Space, enablers for meaningful data reuse. This will be a lot of interoperability and code once use multiple for the data. And also, and then in August, September, depending how the summer break runs, we have then a third webinar, investments and regulations for better data sharing and data reuse, what is needed. So here I come to the final page. I see we have still 38 participants. Thank you for being really patient with us. Please fill in the follow-up survey, and I'm now asking any team members or anyone else who would like to make a final comment. Anyone still in the row? Mark, Luc?
No,
Okay.
let's not delay people to go back for lunch
okay,
and then to continue their meeting. So thanks a lot to everyone for your participation. And this webinar was the first one of a series and of a work program. We have foreseen 9 in total. So let's keep in touch and follow what we are announcing on our website. Thanks a lot for your participation.
Okay, thank you, Mark. Thank you, everyone. So this first webinar in this series is closed. Have a good day. Enjoy the holiday tomorrow and the weekend. Bye-bye from here.
Thank you.
Thank you.
Bye.
Thank you. Bye-bye.